You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is October 4th, 2024. Our topic is an update on biologics in asthma and other allergic disorders. This is presented by Dr. Salman Aljubran. He is an Associate Professor of Pediatrics and is the Associate Program Director of Allergy Immunology Fellowship at Children's Mercy Hospital, UMKC School of Medicine.
Good morning, everybody. My name is Salman Aljubran. I'm one of the faculty at Children's Mercy Hospital and associate professor at UMKC University of Missouri, Kansas City, College of Medicine, Kansas City, Missouri. Today, we're going to talk about an update on biologics and asthma and other allergic disorders. This is going to be, I think it is the last lecture of the summer series, and we'll proceed. I have none to disclose today. So we're talking about asthma. So, as you know, asthma is a very common chronic disease. Affects about 300 or 339 million worldwide, including about maybe 19 million adults in the US and up to 6 million children here. Definition of asthma, it's difficult to define asthma. The more you know about asthma, the more complex it gets. So a simple definition is a complex disorder characterized by variable and recurring symptoms, airflow obstruction, bronchial hyperresponsiveness, and underlying inflammation. The interaction of these features of asthma determines the clinical manifestations and severity of asthma and response to the treatment. Another way, it's a complex heterogeneous disorder with multiple phenotypes, and we're going to talk more about phenotypes in the coming slides. Asthma can be a lot. Conditions could be controlled, could be uncontrolled, could be severe. And we know that up to 10% of patients with asthma would have severe form, and their care is estimated to be to count for 60% of the costs associated with asthma treatment. This is a little bit of a busy slide. Just give you how we can define or how we can categorize asthma, and we have two classification. We have the what we call type 2 inflammation, or high type 2, or we have non-type 2 or low type 2 inflammation. It starts with the adaptive immune system interacting with an allergen that will activate or interact with the what we call the TSLP, which is thymic stromal lymphopoietin, and that end up with activating TH2 or the innate lymphocyte 2, and lead us to secreting of the type 2 cytokines, which are 3, 5, and 4, 5, and 13. Just a little bit. The slide is a little bit small on my side, so like I'm not able at my end, I cannot see it. But so I said like 4, 5, 13. That eventually need to give you a cascade of events, end up having the symptoms that we see with hyperresponsiveness, remodeling, mucus production, smooth muscle constriction, and hypertrophy. And the same thing, even the type 2 can be activated through the pathogen or irritation and give you the same thing. Or if you end up triggering interleukin 33, end up having TH17, which eventually will activate neutrophils and give you the non-type 2 kind of inflammation. This is just a little bit of basic review, just to understand where we're going to target these, or the biological agent target any of these cascades. So I said earlier, asthma could be controlled, and controlled difficult to treat or severe. And controlled asthma can include one or both of the following. You have poor symptom control. You see a patient with frequent symptoms, flare up, needing a lot of relievers use, short-acting beta agonist, and you have limited activity due to asthma symptoms, and waking up at night due to asthma symptoms, and or you have frequent exacerbation that defined by 2 or more per year, requiring oral corticosteroids, or you have a serious exacerbation 1 or more per year, requiring hospital admission. Difficult to treat asthma can be defined that's asthma that's uncontrolled despite prescribing medium or high dose inhaled corticosteroid with a second controller, usually the long-acting agonist LABA, or with maintenance of oral corticosteroid, or that requires high-dose treatment to maintain good symptom control and reduce the risk of exacerbation. Severe asthma is an entity or subset of difficult to treat asthma that's been defined as uncontrolled despite adherence with maximum optimized high-dose combo therapy, inhaled corticosteroid and long-acting beta agonist treatment, and management of the contributory factors, or that is worsened when high-dose treatment decreases. So sometimes you have controlled with these medication. When you try to step down, you're going to have recurrence of the symptoms. We came along with asthma treatment. Asthma treatment have evolved from bronchodilators, and that was in the 60s, early 70s, till we got the inhaled corticosteroid in the 1990s, and early 2000 we were able to introduce biological agents, and now what we have what we call precision medicine, and that's what we're gonna try to talk and address today. So 90% of asthmatic patients will be able to get their symptoms under good control with the stepwise approach. Like as we can see, just regular someone who has asthma symptoms, you start on combo therapy or inhaled corticosteroid. Eventually, most of these patients will be able to get their symptoms under good control. Unfortunately, around 10% will continue to have symptoms despite having taking all these medications and addressing comorbid conditions, adherence, spacer use, all this stuff. And then we can get precision medicine or personalized medicine is very important, because especially if you're going to start using biological agents, which are very extremely expensive, right? And could be associated with side effects, adverse events. So you want to pick the right medicine for the right patients. Therefore, understanding the phenotype and the endotype would help you to determine the appropriate treatment. As you can see, phenotype is what we see, and usually it's the outcome of the interaction between genetic factors or genes and the environment, and say the gender, age, obesity, ethnicity, and definitely smoking history is very important. The endotypes, and at the other end, is a specific biological pathway explains the stuff that we see of that phenotype. And for endotypes, it's the stuff that you'd like to order. You get a blood test, you try to assess IgE level, eosinophils, you can get sputum in the past, you get eosinophils, and you can other, such as exhaled nitric oxide. And eventually you'll be able to determine or identify the best therapy for your patients, and it's called tailored therapy. This is just the workup that you can do to characterize your patients and help you whether this is a type 2 high asthma or this is a type 2 low asthma. And this is the stepwise management as per this is the GNAT 2024. Give you the information, and you have two pathways. You have the preferred pathway, the first one, or track, and you have the track 2. The only thing I need you guys just to look at step 5. This is when we consider or include the biological agents that have been approved by the FDA within the US. Moving on to understand biological agents, we need to define what are the biological agents. What do we mean by that? Biologics are a substance that is made from a living organism or its products and is used in the prevention, diagnosis, or treatment. These include antibodies, interleukins, vaccines, and as you might know, most biologics in clinical use are antibodies. Monoclonal antibodies are antibody produced by a single clone of cells, and they recognize unique epitopes or binding sites on a single antigen. If you're interested in nomenclature, the World Health Organization have a nice website, and they created the INN committee to name biological agents. Since early 2018, any monoclonal antibody will have three parts of their name. You have the prefix, which is random, and it's up to the manufacturer to come up with that part. And you have the stem, which is mAb, and that's for all the monoclonal antibodies. And you have the subsum A, and that indicates the target class. Are you targeting interleukins? Are you targeting a specific tissue, bacteria? This indicates. Before that, we had four parts: the prefix, the subsum A, B, and SEM. The subsum B used to indicate is based on the species that you're obtaining the monoclonal antibodies, and they say, is it based on from mouse or rat? Now most of the monoclonal antibodies are humanized, so that part makes sense to be omitted or taken out and make it shorter to come with reasonable names. So monoclonal antibodies, and we're grateful for the hybridoma technology that was produced in 1975, and the two scientists came up with that technology, were awarded the Nobel Prize in '84, and it did help us a lot, because now we're able to produce monoclonal antibodies in really huge quantities. We started with full mouse 100%, and that came up with the this first infusion usually will go well, but afterward you end up having adverse events or systemic reactions, and now we're able to have full humanized human monoclonal antibodies, and that definitely helped a lot to avoid all the possible consequences of having foreign body associated with the monoclonal antibodies. We have about 5 FDA-approved biologics for asthma, and hopefully we'll be able to address all these in the coming few slides. And this is just to illustrate the location or the position where these biologics acts. It's a little bit busy slide, I understand, but that helps you to just locate if you have interest to find out exactly where the pathway lines up can be found in this illustration. All right, so we're going to start with omalizumab. It's an anti-IgE therapy. Omalizumab been in the market since 2003. It's a recombinant humanized IgG1 monoclonal antibody that binds to the Fc region of the Ig molecule. As you can see, it binds to the free IgE, so it does not bind to the bound IgE, so it binds to the free IgE. Eventually, that will lead to decrease in the expression of the high affinity receptor, which is the Fc-εR1, and eventually that will decrease mediators released by mast cell. Eventually, you end up having less allergic reaction. So this is the basic concept of omalizumab. It has a half-life. It's variable, but it could be up to 21, which is similar to the human IgG half-life. Usually it takes up to 2 to 4 weeks to have a steady state. So it peaks within the first injection, but you need at least 2 to 4 weeks to have a steady state of the medicine. Right. All right, so indication. Omalizumab is indicated for moderate to severe persistent asthma, inadequately controlled with inhaled corticosteroid. The criteria includes as well positive allergy test to indoor allergens, and for dose calculation you have to have an IgA level of 330 to 1300 international unit per milliliter for kids 6 to 11, or 30 to 700 international unit per milliliter for 12 and above. This is within the US, and outside the US they can go up to higher than that, and studies showed that omalizumab will work even with either outside the range approved for omalizumab. And you have to have a body weight between 66 to 33 pounds. So omalizumab for asthma requires the pre-treatment IgA level and body weight to be able to give the dose. Omalizumab introduced to the market back in 2003, so we have more 20 plus years of experience with omalizumab. The initial studies were conducted with only inhaled corticosteroids with no or without concomitant LABA, and omalizumab did improve asthma exacerbation by about 45%, decrease hospitalization by 85%, and decreased or allowed to decrease the dose of the inhaled corticosteroid. When they conduct studies with the combo therapy, omalizumab was able to reduce exacerbation by 25 to 35%, and the IgE level does not predict the response to omalizumab, but it is required for the dosing for omalizumab. Initially, in 2003, it was approved for adults and adolescents 12 years and above with uncontrolled moderate severe allergic asthma. And in 2018, the FDA extended the approval for omalizumab for kids 6 years and above for the same indication, moderate to severe persistent allergic asthma not controlled with inhaled steroid use. Omalizumab does not give you remarkable improvement in FEV1. There's no much data that support omalizumab use or decrease in oral corticosteroid. Definitely, it does decrease the inhaled corticosteroid, but not the oral corticosteroids. Omalizumab, there's some studies that helps with viral-induced asthma, especially in the fall. So sometimes you can consider omalizumab just during the fall season for viral-induced asthma because the study showed that it does help in that category. Omalizumab has a black box warning for anaphylaxis. The rate is 0.1 to 0.2. It's very low, but it does exist. And recently, the last few years, omalizumab got home indication, and as long as you fill the criteria that patient has no prior history of anaphylaxis, and the first 3 doses need to be given at doctor's office or under observation, and eventually it's up to the provider or the treating physician to decide whether it's really a good idea for the patient to get omalizumab at home. We have enough experience with omalizumab. It's been in the market since 2003. So we have enough data. I should not say enough data. We have limited data about omalizumab with pregnancy. So the FDA says that if a fetal risk cannot be ruled out, we have reassuring data, but still limited. So by the end of the day, it is going to be shared decision with the patient, whether if you have patients who are pregnant and already taken omalizumab, the question comes in, can that patient continue with omalizumab or not? So it's going to be shared decision. The data is reassuring, but still limited, despite we have omalizumab for the last more than 20 years. Moving on to interleukin-5 antagonist, we know that interleukin-5 is important for eosinophils recruitment and proliferation. We have 3 products approved for asthma treatment. We have mepolizumab, risoluzumab, and benralizumab. Mepo and risoluzumab are interleukin-5 antagonists. They bind to interleukin-5. Benralizumab binds to interleukin-5 receptor. Mepolizumab has an interesting history because initially in the early 2000s, when mepolizumab was used in IV and was given for all asthmatics without looking to the phenotype or the endotypes, the results were negative. So that was a little bit of setback. And afterward, they went to review their studies, and they decided to go with the eosinophilic phenotype, and then we had really good outcome. So mepolizumab is humanized monoclonal antibody against interleukin-5, inhibits eosinophilic inflammation, reduces the number of eosinophils in both sputum and blood, because the initial study is done with the sputum, and then FDA said like we need something practical, so now they decided to come or measuring the eosinophils in blood. It's approved for add-on maintenance treatment for patients 12 years and above for severe asthma and eosinophil phenotype. That was in 2015. So it took them a while to get the approval and trying to identify the subset of patients that will benefit from this medicine. And in 2019, the FDA extended the approval for children 6 and above. So mepolizumab now approved for children and adults 6 years and above with severe persistent asthma with eosinophilic phenotype. FDA does not require specific eosinophil count as long as it can be classified as eosinophilic phenotype. The studies done with mepolizumab required, or they included patients with eosinophils of 300 cells over the last year, or eosinophils of 150 on administration of the medicine. In the early studies, it's been noticed that patients who received mepolizumab end up developing herpes zoster. It's very limited, maybe up to 3 to 4%, but now it is in the package insert, and patients who are eligible, usually 50 years and older, it's recommended to get them the vaccine at least 4 weeks before initiating the medicine. Mepolizumab and other biologics, they're not immunomodulators, so patient will return to the previous asthma state. Eosinophil count will go back to the pre-treatment levels once you stop mepolizumab, and it takes up to 8 to 12 weeks to go back to the previous state. This is the initial studies with mepolizumab, and this is the MENSA study, and initially they had a good or positive outcome with the IV, and they tried to decide whether sub-Q would give a similar result, and this is when they decided to go with mepolizumab 75 IV versus mepolizumab 100 sub-Q, and it showed that the rate of exacerbation was reduced by about 47. And the studies continue to come by for mepolizumab, and they did conducted about 2 to 3 studies afterward, and they noticed that there is 50% reduction from baseline and improvement in asthma exacerbation, and they noticed that mepolizumab decreased the use of oral corticosteroid up to 50%, and they found that 14% when 4 patients were able to be weaned off oral corticosteroids. Moving on to risoluzumab, it's a humanized interleukin-5 antagonist. It's approved for or add-on intravenous therapy every 4 weeks for patients with severe asthma, not controlled with the standard care, and patient has to have eosinophilic phenotype. The way you dose risoluzumab is given IV is 3 mg per kg and given every 4 weeks. The initial studies was well tolerated in moderate severe eosinophilic asthma, and there were no concern about safeties except for risk of anaphylaxis. This is the another biological agent beside omalizumab that carries the black box warning for anaphylaxis. The risk of anaphylaxis with risoluzumab is about 0.3. The initial studies with risoluzumab conducted with eosinophil count of 400, so definitely the higher the number and the more the frequency of exacerbation, the better the outcome and the better symptom control with the interleukin-5 biological agents. The common side effects for both risluzumab and mepulizumab, and headaches, upper respiratory tract infection being noticed in patients receiving this medication. Benralizumab, this is the third interleukin-5 antagonist. It's a humanized monoclonal antibodies against the alpha chain of interleukin-5 receptor, and this is unique because the first two are interleukin-5 antagonists. This one is interleukin-5 receptor, so binds to the receptor itself, and that's a unique feature which induce eosinophil apoptosis and can be through antibodies-mediated, cell-mediated cytotoxicity. Benralizumab approved for add-on therapy for patients with severe eosinophilic asthma not controlled at the age of 6 and above. And another feature for benralizumab, that first 3 doses given every 4 weeks, the first 3 doses, then you space it out to give it every 8 weeks. So this is another feature that distinguishes benralizumab among the interleukin-5 biological agents. And it does reduce annual exacerbation up to like 40 to 50%. And it does reduce the use of oral steroid. And moving on to dupilumab. Dupilumab is a full human monoclonal antibody to the interleukin-4 alpha receptor unit, and eventually that will block the signal for interleukin-4 and interleukin-13. It significantly reduces asthma exacerbation in moderate to severe asthma patients with eosinophilic types, and usually the rate of asthma exacerbation reduction 50 to 70%. That's really remarkable, and it does decrease the need for oral corticosteroid by 50%. And one feature of dupilumab, it improves the FEV1. And you can have patients be weaned off oral steroid, and steroid-dependent asthma is one of the indications for dupilumab. And just recently, I think last week, dupilumab got the approval for COPD, so as add-on treatment for some patients with COPD not controlled with their current standard care. The last biological agent approved for asthma is targeting the TSLP, which is the thymic stromal lymphopoietin, and it is an epithelial cell-derived cytokine produced in response to environment and pro-inflammatory stimuli. And if you remember the first slide, I think I have another slide that shows where it's at. And TSLP is highly expressed in airway for patients with asthma, and TSLP level correlate with Th2 cytokines and disease severity. And you can see this is where we have this already, or the latest biological agent approved blocking TSLP, and that's going to be, you don't need to do any kind of workup for patient characterization, whether it's T2 high or non-T2 kind of asthma. And the tezepelumab is the one that just approved in 2021 as add-on maintenance therapy for patients with severe asthma, adults and children aged 12 and above. And it is 1 dose to 10 every 4 weeks. And choose that it does work, help with asthma exacerbation, and improve lung function test and get asthma under better control. Home versus office. Currently, most of the biological agents are approved for home administration, except for risluzumab, which is the IV one, and that still need to be given at healthcare setting for observation, and does carry the risk of anaphylaxis 0.3. All of the other medication, benralizumab, dupilumab, mepulizumab, omalizumab, have now home indication. Omalizumab, the patient has to meet the criteria of no history of anaphylaxis, and the first 3 doses of omalizumab need to be given at the office, and then based on the treating physician to decide is a really good idea for the patient to continue the omalizumab at home. and you need to have an epinephrine auto-injector when you send patients with omalizumab at home, given the risk of anaphylaxis is still there. This is just a summary slide. Tells you that we have these 5 biological agents approved for asthma, omalizumab, age 6 and above, for moderate to severe asthma and other indications, which we will talk about in a few minutes. The interleukin-5 mobilizumab and risoluzumab, they're mobilizumab for 6 and above, the same thing for severe asthma with eosinophilic phenotype, risoluzumab 18 and above, and this is the one with given IV. Benralizumab is interleukin-5 receptor antagonist and given or approved for 6 years and above. Dupilumab, the interleukin-4 receptor, blocks both interleukin-4 and interleukin-13 cascade. It's approved for 6 and above for moderate to severe eosinophilic phenotype asthma. And the latest one that approved 3 years ago, the tezepelumab is the anti-TSLP. It's approved for severe asthma with age 12 and above. This is an algorithm because now we have 5 biological agents, and sometimes it is difficult to decide which biological agent is indicated because, you know, the costs associated with it, and some biological agents have risk of anaphylaxis or other adverse events, and that's something I forgot to talk about with dupilumab. Dupilumab, you'd worry about conjunctivitis, and this side effects seen in patients with atopic derm more than asthma, and eosinophilia, because it's been known that dupilumab can increase eosinophil count, so something that you want to keep an eye on, especially like 3 months after treatment. So side effects possible, so you want to maximize the treatment for your patient and try to pick the one that's ideal and will get the patient the best asthma control. That's something for you to go, and we have a couple of clinical vignettes that can help us to navigate this kind of algorithm. Suboptimal responders. So what does that mean? Because when you start biological agents, it's primitive that you have to consider evaluating whether this agent is really doing the job, and that will be based on your treatment goal or what you'd like to achieve. Because are you just looking for symptom control, decrease in medication use, improve the quality of life? Are we trying to decrease asthma exacerbation, decrease in health care utilization, frequency of frequent ED, urgent care visit? Are we trying to improve the lung function test or the lung for this patient, or we aiming just to reduce the daily oral corticosteroid? I know that now with all the advancement in asthma treatment, rarely we see patients needing daily steroid. In the past, it was a major or a big problem that a lot of asthma treating physicians encounter. But now we don't see much patient needing daily steroid to control their asthma. Still we have, but not as big number as used to be. So you have to have a plan when you start the biological agents, and because that would help you to pick which agent you'd like to use. So an algorithm to assess suboptimal biological response. So the question comes in, why, let's say you start the treatment, and for 6 months really a good time to revisit or follow up with the patients and try to assess if there is improvement with the biological agents, or are they getting better, not getting better, or maybe some improvement but not much. So if you see patients that you see there's some improvement but not where you want them be, especially 6 months out of treatment, then you have to ask the question, what is the problem? Is it medication related? Is it disease related? Is it patient related? Because you have factors. If it's medication related, okay, is it because of the dosing is not enough? Do I need to change the dose? Is it because we have anti-drug antibodies? Do we need to measure these? Is it we have problem with the side effects or complements, the position. So that would help you to assess the problem and try to come up either changing dose or switching different medication. Or is it really disease related? Is it a problem? Are we look at, do we need to do further workup trying to assess this is like really T2 high inflammation, or maybe this is T2 low inflammation that would help you to decide or switch to a better agent. And is it really patient related? I mean, especially with home administration, we know that patients always non-compliance, always a big deal for all of us, because we see patients asking them to take their daily inhalers is difficult, and if they have to use biological agents either every 2 weeks or once a month or every 2 months, are they going to be able to take the medicine? Are they going to be able to adhere to that regimen? So something that you always want to ask and see adherence and reassess adherence, or maybe you are having or encounter poorly controlled comorbidities, and then maybe optimizing the comorbid condition treatment, or you want to start different biological agents that will address that comorbid condition that the patients have. Gaps in biological use in asthma. Starting with standardizing the use of biologics, we know that unfortunately there's no clear criteria for responders or the suboptimal responders. When there's no clear cut, like when do you consider failure treatment? Is it really like 4-6 months? Is it 12 months? And that will be based on the treatment goal. Let's say if your goal to decrease asthma exacerbation from patient experience 1 or 2 per year, then maybe you want to wait for 12 months to assess that goal, because that would be a big difference from, let's say, someone who's been taking daily oral steroid. If your goal is to decrease the daily steroid, that can be achieved early on. You don't need to wait for a year to see if the medicine or the biological agent is working or not. And the duration treatment in, let's say, in responders, how long should the patient be? Is it like indefinite, lifelong? When do I need to revisit? And when the patient really well controlled, do I need, when can I consider stepping down or decrease the dose, or increase the frequency? And you need to identify other factors that contribute to failure, and definitely do we need to measure the anti-drug antibodies. Like some, we know even the studies that it's been documented, sometimes up to 8% patients might have anti-drug antibodies, and are they clinically meaningful? Not sure. So that a lot of stuff that or items that we need to address and standardize to help the doctors and patients at the same time to have a clear plan, because just starting the medicine really easy and good, but you have to have a plan afterward. What you need to do, how long you need to be on this medicine, and what you need to look for, and when do you consider at least stepping down or decrease the dose or decrease the frequency. Definitely cost is a big deal with these medications. They're very expensive, and that's why upfront you try your best to pick up the biological agent that's suitable to your patients. And unfortunately, by the end of the day, insurance will dictate the products they will approve for the patient. But upfront, you should do the work, and you try to maximize your options, and hopefully it will get approved, or you need to do prior authorization if you have a good reason why you think this is the best agent for your patient. There's no head-to-head comparison between biological agents. I know now we see some studies that try to compare, but not head-to-head based on the available data, and try to little bit give you some information which one is better than the other, but there's no head-to-head comparison because these medications are expensive, and we have difficulties getting one approved. What if the patient needs two, and we didn't have enough data to look, is it really safe to use two medications same time? It's going to be based on the risk and benefits that the treating physician will address with their patients. Long-term safety, I mean, we have omalizumab for more than 20 years, so we have decent experience with that biological agents. The others, not much, maybe 3 to 7 years in the market. So we don't have much information about long-term safety of these agents. So we have a lot of things to learn ahead of us, but hopefully in the future we'll come up with answer to these questions and try to address the gap available now, and hopefully it will be available in the coming few years. So what next is something that I'm trying to say, good idea to try this, that if you have a patient who's been on Biologics for more than a year and you notice that the goal of therapy has been achieved, let's say the goal was to decrease exacerbation, for example, and the question comes in, what do you need to do next? This is a little bit of an algorithm or suggestion that you might consider to use, that is say, yeah, patient doing great. Do I need to reduce the biological dose by 25% or increase interval? Say, instead of giving it every 4 weeks, maybe give it every 6 weeks, and then reassess in 3 to 4 months. And yeah, patient continues to do well, just go back and try either to decrease the dose or increase the frequency and reassess in a few months. I mean, if you notice that doing this, patients start to have more symptoms, maybe can go back to the previous dose or the previous frequency. And the question comes in, why we need to reduce biological agents. As listed here, you can see target of the biological may be lower after therapy, disease may be modified, and sometimes the agents modify the comorbid condition, and now you have less need to that dose and may need lower dose to give you a good symptom control. But this is part of the gap in knowledge and information Biologics, and this is just a suggestion how to go by, but hopefully in the future we'll have more information to help us to have a standardized way of managing patients while on biological agents. All right, moving on to Biologics and other allergic disorders. Chronic rhinosinusitis with nasal polyposis. It is a chronic problem, affects 5 to 12% of world population. The current standard of care in the US, that patient after having surgery, then you might consider biological agents.
Dr. Aljubran?
Yes.
I can't see your slide.
You cannot? Okay.
I don't know if it's just me, but...
Yeah, I can see it. So
I can see him too.
Oh, okay. And I'll just leave and rejoin, no worries. You're good.
Oh, okay. Sorry. All right. So you were saying, like, at least the European guidelines, they have a little bit some information for us that they divide, let's say, patients either have a history of surgery, sinus surgeries, or no history of surgeries, indicating that the patient does have bilateral nasal polyps. If they have history of surgery, then they need to have 3 criteria of the 5 below criteria. If there's no history of surgery, then they need to meet 4 out of 5. And the 5 criteria are the evidence of type 2 inflammation, need for systemic steroid 2 or more over the last year, significant impairment and quality of life, and loss of smell, and diagnosis of comorbid asthma. I understand that even the US, if patient after discussion about the option surgery and they don't want to go for surgery, still biological agent is an option, but the European has this is a little bit of algorithm that can help and guide us through the process. A lot of medication or biological agent tried for asthma, for chronic rhinosinusitis with nasal polyposis. We have currently 3 FDA-approved biological agents. We have dupilumab, approved in 2019, and the dose 300 milligrams sub-Q every 2 weeks. We have omalizumab, approved in 2020, the dose based on weight and total IgE. Mupilumab, approved in 2021. The dose is 100 sub-Q every 4 weeks. Moving on to Biologics and chronic urticaria, the only one approved is omalizumab, and the benefit of omalizumab is independent for total IgE. So with the chronic urticaria, you have two FDA-approved doses, 150 and 300, and given every 4 weeks. And significant and clinically meaningful effects were seen for both patients, for patients receiving either 150 or 300. Adult patients usually start with 300 and then try to taper after having a good symptom control. This is the same mechanism of action that we discussed earlier, more or less the same information. These are the studies used to get omalizumab approved for urticaria. And this is just a way to help you, because the question comes in how long the patient need to be on omalizumab. This is maybe an algorithm to little bit help you to decide when do you need to consider stepping down or increase the frequency and reassess after a while. That helps you. If you start with 300, patient doing great, let's say 6 months out, and then okay, maybe you want to decrease to 150 and reassess, or maybe you want to increase the frequency. And the only problem with the frequency sometimes is insurance. You want to make sure that insurance will continue to provide you with the medicine since they approved it for every 4 weeks. If you switch to every 6, maybe something that you might run into, but it's still an option and reassess, because we know that time usually at your side with urticaria, patients get better with time. So it's a good idea not just to start the medicine and keep them there indefinitely on omalizumab. Biologics and food allergy. Recently, this year, we got omalizumab approved for food allergy. It's the same concept. It's based on body weight and total IgE, and can be given every 2 to 4 weeks. Things that you want to keep in mind: this is a way to decrease the systemic reaction with accidental exposure, does not induce tolerance. So patients need to understand this is not a cure for their food allergy. It is to help them to minimize or avoid systemic reaction with accidental exposure. Although IgE level rapidly decrease with omalizumab, but we have to understand that we have an IgE only bound to the Fc epsilon R1, so patients should not expect protection against the allergen immediately after dosing. That's something you want to make sure that the patients are aware of. And definitely it's really great step with food allergy, adding an extra option for our patients, but comes with a lot of questions. The same thing, how long you need to be on this medicine? Is it efficacious for all the food allergies, or just one, peanut, milk, egg, or tree nuts, or wheat? So a lot of unanswered questions, and hopefully with time we'll have some answers. And the question comes in, is it helpful to consider oral immunotherapy, peanut oral immunotherapy while taking omalizumab? So a lot of questions need to be addressed, hopefully in the coming few years, when it comes to biological agents as a treatment option for food allergy. For atopic dermatitis, we have dupilumab, approved back in 2017 for moderate severe atopic eczema with adults. And I said earlier that one of the side effects that we see with dupilumab is conjunctivitis, especially for eczema, but not much seen with asthma. And back in 2020, they approved it for 6 years and above, and 2022 got the approval for 6 months. So dupilumab can be used for patients with moderate severe and controlled atopic dermatitis 6 months and above. I know that we have a lecture on dupilumab, so that's why I did not dive much when it comes to atopic dermatitis. Biological for esophagitis, AUE, we have one agent, dupilumab. In 2022, it was the first agent approved for AUE, and now it's indicated for treatment for adults and pediatric patients age 1 and older, weighing at least 15 kilos, and they have different dosage based on weight. And we have a biological agent for hereditary angioedema, lanadelumab, and that was approved in 2018. All right. So we have 10 minutes to go over the clinical vignette. Before going to the clinical scenarios, do you have anybody has any questions? Or you want to wait till the end of the clinical vignettes? Whatever you like.
I have one question I can wait for at the end.
Sure, perfect, awesome. So hopefully, guys can help me with this scenario. We have a 7-year-old female. She has a history of moderate to severe atopic dermatitis and uncontrolled asthma, with history of multiple hospital admission for asthma flares up. She is currently on combo therapy for the last 1 year. Workup available for her has CBC with differential showing AU count of 600, total IG of 2000, and with positive skin test to dust mite. She's being seen and evaluated by a local allergist who recommended starting biological agents. Which of the following you think is the best option for this patient? Any takers?
I would say dupilumab for both the asthma and the atopic dermatitis to treat both.
That's good. Why not omalizumab, mepulizumab, or risoluzumab? Just for learning purpose, why omalizumab is not a good option with this patient, or maybe it's a good option, but not the best option. Yeah,
omalizumab wouldn't treat the moderate to severe atopic derm.
Okay, see, so I'm trying to get that. This
approved.
patient, yes, so this patient has a comorbid condition, which is atopic dermatitis. So when you try and go through the biological agents available for asthma and for eczema, dupilumab is the one that will help both conditions, right? So that's what I think, because if you patient has allergic asthma, maybe omalizumab would be a good option. Yeah, it is an option, but is it the best option? So that's why sometimes you want to think about the patient's condition, the comorbid conditions, and try to target 2 by 1, right? All right, good job. Now that's really great. Yes, dupilumab. That's the best option, or the best option for this patient. All right, moving to the second scenario, you have a 49-year-old female with a history of chronic spontaneous urticaria with uncontrolled moderate asthma. Which would be a reasonable agent for this patient? Dupilumab, omalizumab, dupilumab, risoluzumab.
Omalizumab.
All right, and why is that?
The one that has the indication for chronic spontaneous urticaria.
All right, and that was easy, right? That's sometimes just easy. Boom, we get both. Awesome, easy pick. But sometimes it can be a little bit difficult to decide. All right, moving on, we have a 45-year-old male with history of uncontrolled severe persistent asthma on high-dose combo therapy. He has negative aerologen panel and absolute eosinophil count of 100. He's being seen by a local allergist and recommending therapy. So which one would be our best option for this patient? Omalizumab, mepulizumab, risoluzumab, or tezepelumab?
So because it's severe persistent, automatically it's either mepulizumab or risoluzumab or
tezepelumab. Okay. Yeah. So which one would be our best option for this patient? I mean, we have to pick one, right? I mean, we have a lot of options, but that's a dilemma. Sometimes you have a patient who might be eligible for a lot of, or 1 or 2 biological agents, right? I'm not talking about this patient, but in general. And then you said, okay, so which one should I start? So that's why you have to go back and try to figure out what I'm trying to achieve. Okay, this patient has comorbid condition, yes or no? Okay, if no, then that would go back to only any biological agent will do the job. Then do you need to classify these patients or endotype these patients or phenotype? That would help me to decide which one's going to be a better option, right? So you said mepulizumab, risoluzumab, or tezepelumab, right? If you go with mepulizumab is approved for eosinophilic asthma, right? Mm-hmm. And we said the criteria for that, you have to have severe asthma with eosinophilic phenotype, anaphylaxis phenotype. The criteria, when they did the study with mepulizumab, it was about 300 over the last year or 150 on administration. So and the higher the eosinophil count, the better the outcome, or the better the symptom control. So this patient's absolute eosinophil count is 100, right? Mm-hmm. So they make us, really, yeah. Do I want to go there? Maybe not, right? So yeah. Maybe I'll keep it aside. I like mepulizumab, but maybe not best option for now. Let's keep it aside and maybe revisit after. Okay, move on to risoluzumab. Okay, Resoluzumab is similar to Omalizumab. It's interleukin-5, right? Antagonist. Requires eosinophilia or eosinophilic phenotype asthma, severe asthma. Resoluzumab studies, they really look into the 400, even more. And I know the FDA does not require specific eosinophil count, but you have to have eosinophilic phenotype. His numbers are 100. So that little bit may not be the best option since we want higher eosinophil count. And Resoluzumab is given IV, so I'm not sure that's something the patient would like to do or not. But something like maybe the same reasons, I would keep Resoluzumab outside for now. I'm moving on to Tezepelumab. Tezepelumab, what is it? The anti-TSLP, right? So it's really great. You don't need any kind of endotype, phenotype. There's nothing. This works for most of asthma type, right? So that would be a good option with this patient to start with.
Yeah.
Because now there's not allergic asthma, not much of eosinophil, so maybe Tezepelumab would be the best option for this patient. And this is what I would pick first, to be honest with you. Does it make sense?
Yeah.
All right, cool. All right, moving on. So we have a 13-year-old female with a history of chronic rhinosinusitis with nasal polyposis, status post-surgery, and history of uncontrolled severe asthma. You reviewed the workup done by her allergist. She was started an abortion agent. She's an ER nurse. Okay, and which agent would be a good option? So let's go back. So how many agents available for chronic rhinosinusitis with nasal polyposis?
I think three.
Three. Awesome.
Three.
All right. So that should be easy, right? Because you want to start the patients, or at least look into the biological agents approved for chronic rhinosinusitis with nasal polyposis, and which one is not out of these is not approved for that condition?
Benralizumab.
Yeah, so that's out. Now back to square one. We have three, at least 3 out of 4. That's good, right? So we have Omalizumab, Dupilumab, and Mepolizumab, right? So what do you think is a good option for this patient? I mean, they're all good. I mean, if you ask me, yeah, all 3 are a good option for her. But what in history make you think maybe one is better than the others?
So she has severe asthma. So maybe Omalizumab isn't the best because it's moderate to severe.
I mean, so Omalizumab approved for moderate to severe asthma. So if you have severe asthma, it's still approved. So you can use it. So Omalizumab approved for moderate to severe asthma. So even severe asthma is an indication for Omalizumab. So that should not be the reason.
I feel like based on her profession, maybe something that's a little bit more easier to like use. Like she doesn't come into the office with like Omalizumab potentially.
See, no, she's an ER nurse, so she does a lot of shifts, morning, nights, evening. So definitely may not be an option for her to get into your office. Especially with Omalizumab, she needs to be at least the 3 doses need to be done in the office, right? So that's maybe she doesn't like. So you have to take in consideration patient preference and their lifestyle. So ER nurse is busy. She's like, no, Omalizumab, I don't want to come to your office. Give me something I can do at home. So like say Omalizumab is out, right? Now we have Dupilumab and Mepolizumab. Which one would be a better option for this patient? And besides shared decision making, but they say you want to suggest one. What do you think would be a good option for this patient? And both are really great. But what feature that make you feel like, this patient, ER nurse, maybe she would like this more than the other? Because you will discuss both medication for her, all the 3 medication, and by the end of the day, she will decide which one works for her. But I'm trying to think up front, like, what do you think would she go for?
I mean, Dupilumab's going to improve the FEV1, but I don't think that's what you're getting at, so I'm not sure if that's a deciding factor.
I mean, no, we did not say anything about lung function here. So, so how often do you get Dupilumab? How often do you administer Dupilumab? Let's say
every 2 weeks.
Okay, right. How often do you give Mepolizumab?
Every 4 weeks.
Once a month.
Initially, right? For the 3 doses, I mean, yes, that would be, but no, that. Yeah, cool. So you have 2 weeks, you have 4 weeks. Which one is better? Yeah.
Mepolizumab.
Okay. Yeah. So that sometimes the frequency. I'm getting at the frequency. Some patients will prefer like lesser frequency. Someone who's busy, they might go like, oh man, 2 weeks, 4 weeks. I might go with the 4 weeks, right? So by the end of the day, it's her decision to make which one she'd like to go. But I think it's good to give them all the options, make sure they're clear about the frequency, the dosage, all the indications to make a really well-informed decision. So mepolizumab would be a good option or maybe a better option, but dupilumab is still a good option for her. So I would have a discussion with the patient and come up with which one would be good option fitting her lifestyle and her therapy options. So mepolizumab would be I think I'm just trying to get the frequency here. That's what I'm trying to get at. All right. So you have a 9-year-old male with history of AUE, atopic dermatitis, and controlled moderate asthma. Which agent would be a good option for this patient? Is it tezepelumab, omalizumab, dupilumab, reslizumab, benralizumab? It should be easy, right?
Dupilumab.
Dupilumab.
Why is that?
I think basically it touches on all of them, the EOE, atopic derm.
Yes, good. See, the comorbid condition. Now we're looking at comorbid condition is dupilumab a better option. Tezepelumab, not a good option for a lot of reasons, right? All this stuff because of the age and other indications. But yes, what I'm getting at is AUE. So if you have comorbid condition, you would like to have an agent that might be really covering all these three together. All right, good job, guys. All right, last one, I guess. 57, male with the body weight of 150 kilos, history of frequent admission due to asthma symptoms. He was in omalizumab. Okay, for 1 year, he continues to have symptoms. What would you recommend for this patient? So to establish, okay, so first option, okay, you're already in omalizumab. I didn't have time. Let's continue the omalizumab for another year. Second option would be dupilumab, maybe, reslizumab, or tezepelumab. So what do you think is a good option with this patient?
So his goal sounds like to decrease hospital admissions. Are those decreased?
I mean, he's like, he can have symptoms and not doing well. So we have a patient who is currently on a biological agent for a year, but symptoms still not controlled. So he's not happy with the symptom control. So what do you think? So like, oh, it's been a year, give it another year. Would that be something that you think would be reasonable?
It sounds like if he's
No.
No, right? I would not,
Yeah.
right? Because patient's not happy with what's going on. So definitely, it's been 12 months. That's good time for us to say, yes, this is a good option or not. Patient's not happy and he still have symptoms. So that's why it's a good idea to have clear expectations and making sure that you're addressing the patient's symptoms or goal therapy. So yes, continue with the omalizumab, definitely not an option. All right, moving on we have 3 options now. We have dupilumab, reslizumab, tezepelumab. Which one should we consider?
Is there a weight restriction for any of these? Like, does that matter?
I mean, the question comes in, why you would worry about weight restriction? Dupilumab is not given by weight. It's not really based to say omalizumab is based on weight, right? You have to calculate omalizumab by weight, and which other medication can be given based on weight, but there's no restriction. Reslizumab is 3 mg per kg. So this is based on weight. So we have 2 medication can be given based on weight. Dupilumab and tezepelumab, no, they're not based on weight. You need to have the weight to calculate the dose. So there's sometimes based on the weight you have different doses, but it's not incorporated with the calculation. If that makes sense.
Yeah, thank you.
Sure. So what is the? What do you think? So what's if you dissect this patient? It's easy, right? You have patients not controlled omalizumab, and his weight is 150, right? So what I'm trying to get at is the weight here. So which one can be based on weight? The only option is that could be weight. Sometimes maybe you need a higher dose. And if it's really weight based, reslizumab would be a good option for this patient. Dupilumab why not dupilumab? Because like, well, I don't see anything about eosinophilia. So, I mean, the person who wrote the question did not want me to book dupilumab, because otherwise you would add like eosinophil count here. There's no eosinophil count, so, and I cannot assume this is eosinophilia, right? And most likely it was an omalizumab, most like an allergic asthma, yes, but nothing else. I cannot assume it's eosinophil based. So that's dupilumab making me, I don't want to worry about dupilumab, to be honest with you. Tezepelumab is an option. It's fixed dose, and he fits the criteria for age, but I think what I'm trying to get here is based on the weight. So that's what I'm trying to, like, we have two biological agents, the dose can be calculated based on weight. Omalizumab is the one. The second one is risoluzumab. All right. So I would say risoluzumab would be a good option given his weight. And he is in the upper limit for weight for omalizumab dosing, to be honest with you. Okay. So Michelle, you had questions?
Yeah, I was going to say for like heavier patients, do you lean towards the weight-based?
Yes, I think that would be a good option. Sometimes, I mean, if they have, like, if they have special phenotype, then good idea to start with the first medicine, but it's good to take in consideration the weight. But sometimes at the heavier weight, then maybe you want to start a biological agent that's based weight, because that give you some flexibility and higher dose. Yeah, that's something you would take in consideration, definitely.
Got it.
All right. I think that was the last vignette, and that's just the algorithm to help you. The same thing can help you to decide based on. We have a lot of algorithms out there that can help you to decide on which biological agent you need to use, and based on the criteria, based on what you'd like to do with the steroids, the eosinophils, and other stuff. All right, perfect. So Michelle, you should have a question for me.